morning. Super happy to be here. Mike Siah, I'm a vascular surgeon, and I'm going to talk about something that also is, what entire conferences are dedicated to, as my disclosures. So when I think about BTK revascularization, you have to think about the challenges associated with treating the BTK vessels, right? Patients oftentimes are sicker than their SFA counterparts. The arterial non-invasive studies that we rely upon are often unreliable due to the medial calcific disease these patients have. The arteries are small. When you ultimately determine that you're going to treat these patients, you're usually pretty far from a distance standpoint from your actual treatment area. These blood vessels are oftentimes more tortuous, or you're dealing with tortuous iliac arteries, which make the anatomy a little bit more challenging. The lesions are longer. They're often very much more calcified than their SFAs or iliac lesions. And then when we talk about data, the SFA's got so much more RCT data than the treatment of tibial arteries. So it's kind of in a frontier sort of area when we talk about optimizing our therapies in this location. But for me, it feels like I'm walking into, when I go to these conferences and I look at all the vendor booths outside, it feels like I'm walking into Foot Locker. There's so many different shoes, there's so many things. It's hard to imagine what you need to effectively treat patients. Obviously, historically, everything is compared to open surgical interventions, but not all patients are candidates for open surgery, whether or not they have vein or whether or not their comorbidities preclude them. We talk about the different types of angioplasty balloons. Now, below the knee, conventional angioplasty, POBA, PTA, that's the gold standard to which all other therapies have been and will continue to be compared, right? And in addition to that, in the United States, we don't have access to drug-eluting technology or just drug-coated balloons for the treatment of tibial disease. Now, fortunately, now we do have a FDA-approved scaffold that we can use for BTK treatment, but compared to our counterparts in Europe, where they have a dearth of tools that they can use to treat tibial disease, we're kind of at a disadvantage. But fortunately, in the US, we do have atherectomy available to us, and the use of intravascular lithotripsy has really changed the way in which a lot of people approach BTK disease. So the historical precedent that we use or have to compare things to is just conventional angioplasty, which is relatively barbaric if you think about it. We've been doing the same thing for 30-something years, and what we're doing when we do angioplasty is cause dissections, right? We're rupturing the arterial internal elastic lamina. We're trying to control for the amount of dissection that we do cause, but by inflating a balloon, you are dissecting the plaques off the medial and adventitial interface. And we know, and this has been well documented over time, that there are a lot of limitations with conventional angioplasty, right? Sometimes you simply can't deliver the balloon to the area that you need to treat. Additionally, the implications of angioplasty, whether it's causing dissections, causing elastic recoil, not getting the balloon to expand, to really get luminal gain, are all short-term implications on how angioplasty isn't ideal. But over time, we do also see neointimal proliferation. So dissection happens very often after conventional angioplasty, and we've seen these in the BTK drug-coated balloon clinical trials, but we see it very frequently, right, ranging from 30% to 91% of patients who undergo tibial angioplasty, irrespective of lesion length, dissections do happen, and that can have implications on the clinical outcomes that are most important to us, whether that's wound healing or the need for reintervention. Now, recoil is something we've all heard about. I think everyone has seen or heard somebody talk about this Baumann paper, and this Baumann paper fundamentally is unlike any way any person does angioplasty. So what in this paper it showed is if you do an angioplasty, wait for 15 minutes, and then repeat the angioplasty, 97% of patients had some degree of early restenosis or recoil after successful angioplasty, and that effect was more pronounced in diabetic patients. And on average, that reduction in lumen area was around 30%. Now, at least for me, 15 minutes after I've done a successful angioplasty, the patient's got a closure device and they're on their way back to PACU. So the interesting thing about this paper is no one has ever demonstrated the clinical implications of recoil, and I think that's something that future studies should very easily be able to demonstrate. So obviously, angioplasty has fallen short. Our expectations or our ability to compare angioplasty to open surgical bypass, they're worlds and worlds apart, right? Unfortunately, the specialty therapies that we've tried to apply in the BTK space haven't been successful also. Failed DCB trials, and then more recently, the failed Saval trial have demonstrated that drug-coated balloons or previous iterations of drug-coated balloons don't work well in the BTK space here in the United States, and for whatever reason, Saval had its shortcomings too. Despite that, last year, we had a seminal publication in the New England Journal of Medicine, the landmark Life BTK trial, which was the first RCT to demonstrate superiority of an investigational device over standard of care, conventional angioplasty, for the treatment of patients with critical limb-threatening ischemia and BTK disease. So we know we've got a lot of failed therapies, and we know we have what we have available to us to treat patients. So fortunately, we do have different algorithms that can allow us to sort of optimize our expectations for tibial interventions. And this was a nice algorithm that I use routinely, which advocates for the use of some type of intra or extravascular ultrasound to assess the morphology of the lesions that you're treating. And then beyond that, the techniques used to do angioplasty to get the best outcomes you can possibly do, and how you can intertwine the use of specialty technologies to optimize those outcomes. So the first step for success is to know what you're looking at, right? So this is a horrific looking picture of a mama lioness eating something, but from a different projection, it's actually a mother's tender embrace. So when you're encountering these types of patients, you want a very clear idea of what the anatomy is and what your goals of intervention are. And the goals of intervention, oftentimes you can have an idea of which blood vessel you need to revascularize even before you get to the cath lab or the OR based upon the angiosome or woundosome directed therapy. So depending on where a patient's wound is, you know which blood vessel you want to open. And the woundosome theory takes into consideration the changes that happen due to atherosclerosis. So when you do an angiogram, you can actually see which blood vessel is actually perfusing your wound area. So Dr. Walker is going to talk a lot about how to cross these lesions, but I typically am a contralateral access guy, or I'll get retrograde pedal access. I'm not an antegrade access interventionalist because in Texas, my patients and their body habitus preclude that. But this is a case of a patient with a hallux ulceration. You can see a short TP trunk lesion, long segment AT-CTO. And that perineal artery that reconstitutes does a really good job of perfusing the whole foot with the plantars and the dorsalis pedis. I ultimately elected to cross that anterior tibial artery. I used IVUS to get measurements of the proximal and distal extent of where I was going to treat. Used a tapered balloon, a 253 tapered balloon distally, and then used a specialty balloon to treat the proximal anterior tibial artery. And then at the end of it, you can see a completion IVUS run. You see that the anterior tibial artery and the tibial-perineal trunk are sort of going at the same speed, despite the absence of dissections and the pretty good luminal expansion. So I elected to use one of the Esprit scaffolds to treat that proximal anterior tibial artery. And I think at the end of this, you can see that not only is the AT beating.
Go back one more and go forward.
Oh, there it is. The AT is beating the perineal now, and you see excellent technical result with wound blush to that hallux. So fundamental dogma when we're treating these patients, cross-luminally, if you got to try your best to do so. Can you deliver therapy? If you can't, think about atherectomy. IVUS is critical. And low-pressure balloon angioplasty with specialty balloons will mitigate the shortcomings of conventional angioplasty, recoil dissection, perforation. And in a perfect world, drug therapy, which in the United States is the only thing we have, are BRS, or the bioresorbable scaffolds. Thank you.